Okay, so a little review about our previous discussion. We talked about heart failure, and when we say heart failure, it means that our heart fails or failed with its function, and that is to pump blood all over the body for that our body may have enough supply of oxygen. So reasons why the heart can fail is number one, hypertension, wherein the blood vessels can get damaged due to the increase in the blood pressure. And also coronary artery disease that can block the flow of blood to the heart muscles. So definitely if the heart muscles lack oxygen, it will not contract efficiently, and that will lead to the weakening of the heart muscles. Therefore, we are going to give inotropic drugs for patients with heart failure. When you say inotropic drugs, these are drugs that can increase the force of contraction of the heart. And one example of that is digoxin. But how can digoxin increase the force of contraction? That's through the inhibition of the sodium-potassium ATPase. So this is a pump wherein there is an exchange of sodium and potassium. 3 sodium will go out, 2 potassium will go in, and i-inhibit natin yan. Therefore, there will be a shifting on the exchange. Doon na siya, si sodium, lalabas pa rin siya, pero doon na siya makikipag-exchange kay calcium. That will lead to calcium influx in the cell. And remember, since heart is a muscle, it needs calcium to contract. Pag dumami si calcium, it will really help in the contractility of the heart. So ito yung mga effects ng ating digoxin. There will be increased cardiac contractility. We call that inotropic effect. Okay? And there is cardiac parasympathomimetic effect. Parasympathomimetic ha, hindi sympathetic, parasympathomimetic. So there will be slowed sinus heart rate. That means the force of contraction will definitely increase, but the heart rate will decrease for this. Kasi kapag masyadong mabilis yung heart rate ng heart, isa pa yung nagko-contribute in its weakening. So there is again slowed sinus heart rate and slowed atrioventricular conduction. Our heart beats through electricity. So nagka-conduct ng electricity yung heart natin. Magsuslow down yon. And pag nag-slow down yon, magsuslow down din yung heart rate. Pinapababa natin yan siya for the digoxin. Ang pinapataas lang natin is the contractility. Again, that is due to the inhibition of the sodium-potassium pump or sodium-potassium ATPase, leading to the increase in the calcium inside the cell. So what are the clinical applications now of our digoxin? We have here, ginagamit siya as a maintenance drug for chronic symptomatic heart failure. Okay? So, symptomatic talaga siya na merong yung mga na-discuss natin last time na SOB, tachycardia, decreased exercise tolerance, na-experience talaga ng patient. And then, aside from the chronic heart failure, we also use digoxin for rapid ventricular rate in atrial fibrillation. So this is class 1 type of arrhythmia. Remember, arrhythmia is irregular na heart rate. Now, one type of that is atrial fibrillation. We will have a separate discussion of that, and we can also discuss the digoxin kapag mag-discuss na tayo ng atrial fibrillation or our arrhythmia. Okay? But let's talk about the toxicity of digoxin. Diba, we have digitalis lanata and digitalis purpurea, our plant sources for the digitalis glycosides. Pero ang kinukunan talaga natin, lanata, kasi we want the digoxin, kasi the digitoxin is toxic. However, though Digoxin is less toxic than digitoxin, that is still considered toxic class. So as you can see, masyadong maliit yung tablet natin kasi maliit lang din na dose yung ginagamit natin for digoxin. Digoxin actually has a low therapeutic index. Pag sinabi mong low therapeutic index, ganito yun. If this is the graph class of, ito yung kanyang effective dose, this will be the toxic dose. So masyadong malapit yung index, yung ratio between the effective and the toxic dose. Therefore, dili ta pwede mag-double dose for this. Now, what happened to a patient if he or she experiences toxicity? The nausea and vomiting is common for most of the drugs. The first thing that the patient will experience is diarrhea. That's GI disturbance, okay? Pero please take note that the life-threatening toxic effect of digoxin is cardiac arrhythmia. So na-mention ko kanina that it is a drug for a certain type of arrhythmia, that's atrial fibrillation. But if the patient gets overdosed and magkaroon ng toxic effect, cardiac arrhythmia yon, life-threatening, nakakamatay na toxic effect of digoxin. Now, aside from that, the brain may also be affected. So the patient may also experience disorientation and hallucination. And even the vision may be affected. We call this santopsia. Let me write sa screen na lang para mabilis. You have here santopsia. That is the blurred or yellow vision experienced by the patient na nagkaroon ng toxic effect with the digoxin. Wait lang kay lobat. And just like spironolactone, digoxin can also cause class gynecomastia. Ano nga meaning ng gynecomastia? Who can still remember the meaning of gynecomastia? Okay, very good. There is increased breast muscle size sa mga lalaki. So just like the spironolactone. Pwede din yun siyang i-cause ni digoxin. But again, take note, the first sign of toxicity for digoxin is GI disturbance. That includes nausea and vomiting and also diarrhea. But the life-threatening toxic effect of digoxin is cardiac arrhythmia. Okay, it's a drug for arrhythmia, but it can also cause arrhythmia. Actually, if we're going to discuss drugs for arrhythmia, makikita natin doon na these drugs are used to treat arrhythmia, but their toxicity is also arrhythmia. They can treat one type of arrhythmia, but they can cause another type ng arrhythmia natin. Okay, questions so far about the digoxin? Brand name sa market. What's the brand name sa market na sikat for the digoxin? Very good. It's Lanoxin. Yeah. And it is included sa mga loose tablets natin. Okay? So if there is no question, yeah, naka-loose tabs. Let's talk about the interaction with potassium, calcium, and magnesium. Again, take note, class, our digoxin has a very low therapeutic index, wherein the ratio between the effective dose and the toxic dose is very small. So, hindi pwedeng mag-double dose talaga. And kapag binibigyan ng patient ng digoxin, we have to constantly monitor the patient. Remember, our target here is the heart. Now, aside from the dosing, we also have to monitor the electrolytes of the patient. So what are the specific electrolytes that need to be monitored? We have the potassium, calcium, and magnesium. Let's start first with potassium and digoxin. Remember, the mechanism of action of our digoxin is the inhibition of the sodium-potassium ATPase. Our goal here is for the sodium and the potassium not to exchange via that pump, para lumipat si sodium doon kay calcium. However, if we are going to administer too much potassium in the body, like tataas, the patient will experience hyperkalemia, the effect of digoxin class will be reduced kasi too much potassium can cause competitive inhibition or competitive na antagonism with that of the digoxin sa ATPase, sa sodium potassium ATPase. So before giving the patient digoxin, you have to test first kung normal ba ang level ng kanyang potassium. Kasi again, pag nag-hyperkalemia ang patient, meaning mababawasan ang effect ni digoxin. Kasi matatalo siya doon sa binding sa sodium potassium ATPase ng maraming potassium. Competitive antagonism ang tawag natin dyan. And then, you have the hypokalemia. What do you mean by hypokalemia? Pagbaba naman, yung potassium level ng ating patient, baliktad. The patient may experience toxicity. Kasi wala nang kakompetensya si digoxin doon sa binding site niya kay sodium potassium ATPase. The digoxin is free to bind and maraming digoxin will mean toxicity. Okay? So kailangan balance lang para mabalance din ang activity ni digoxin. So please take note ha, hyperkalemia means no reduced or no effect for digoxin. Hypokalemia is magfa-facilitate ng activity but it may lead to toxicity. Okay, now how about calcium? So remember what we are trying to do here, if we are going to give the patient digoxin, is to increase calcium inside the cell for the muscle to contract. Therefore, if the patient experiences hypercalcemia, marami na siya calcium with this one. Marami na siyang calcium before ka pa nagbigay ng digoxin. Just like the hypokalemia, this can also cause toxicity. It will overload the heart with calcium class. Kasi nagbigay ka pa ng digoxin, pumasok na yung maraming calcium sa cell, tapos marami pa talagang calcium yung patient daan, so daghan na kayo og calcium sa sulod. So again, that will facilitate toxic activity of the cardiac glycosides, the digoxin in the body. And it's the vice versa if the patient experiences hypocalcemia. You have given the patient digoxin pero konti lang talaga yung calcium niya, so there will be reduction in the activity. There will be reduction in the inotropic activity of the drug. So you have to make sure also that calcium is in the normal level. Okay? So sa magnesium naman, it's the opposite for the effect of calcium. Kasi yung calcium and magnesium sa lawas, sa body class, baliktad yan sila. Pag tataas si calcium, bababa yan si magnesium. Oops. Okay? Bababa yan siya. Therefore, if the patient experiences hypomagnesemia, pa tayo mag-type? Wait lang. Ayan. If the patient experiences hypomagnesemia, ano mangyayari? Hypomagnesemia. Okay. That means the patient has increased calcium in the body and that will lead to toxic activity of the digoxin. Okay? Again, pag mag-hypomagnesemia ang patient, kulang siya nag-magnesium. Since opposite ang activity nila ni calcium, toxic activity yan for digoxin. And that's the other way around again for hypermagnesemia. Kasi sa hypercalcemia, magkakaroon ng toxic activity yung digoxin. Itong sa hypermagnesemia, baliktad, there will be reduction. At singon ko, wait lang. Okay. Balik again, there will be a reduction in the activity of digoxin. Okay. So, yan yung mangyayari. Baliktad sila ni calcium. So, class, actually, if the doctors will prescribe digoxin sa patient, the doctor actually should start first with the laboratory result of the patient in terms of the amount of or the level of electrolytes, just to make sure that the patient gets the optimum effect of the digoxin and at the same time preventing the toxic effects. Okay, do you have questions or clarifications before we'll move on to our other positive inotropic drugs used in heart failure? We really singled out the digoxin kasi it's the most commonly used inotropic agent for heart failure. However, if the patient cannot tolerate the effect of digoxin, that's the time we use other positive inotropic drugs. Walay question. So let's start with this drug, which is not really common. We have here the Diuretics. This is actually an investigational drug. When you say investigational drug, it's not really out in the market. It's still on its phase 2 clinical trials. If you can still remember the clinical trials class, pag sinabing animal testings of the drug, like what you did in your research, in your thesis, we call that preclinical trial. Okay? Now, after the preclinical trial, if the animal studies class have shown na the drug is really effective for that certain type of pharmacological action, then pwede na siyang mag-move on into clinical trial. So that's the time there will be an application in the FDA for a new drug. Okay? Ang application is called New Drug Application, NDA. Okay? And then, clinical trials will commence starting with the phase 1. Remember sa phase 1, pag clinical trial, by the way, we are testing the activity of the drug to human subjects na. Okay, human subjects na ito. So phase 1 class will establish first the safety of the drug, wherein the new drug will be administered to healthy volunteers. Again, healthy, walang sakit na mga volunteers. That's phase 1. And what's again ang ini-establish natin, it's the safety, kasi kapag nagkasakit itong mga healthy volunteers natin, that means our drug is not safe. Pag nabagsak yun, we cannot move on with the other phases, or kung nabagsak and we can find solution to the problem with the safety, that's the only time we can move on with the phase 2 clinical trial. Okay, volunteers, take note, volunteers ito. So it's not just giving the drug to group of people without them giving their consent or knowing that you are giving them a new drug that is not really approved yet. Okay, volunteers ito. Now, after establishing the safety of the drug in the phase 1 clinical trial, we are going to do the phase 2. And in the phase 2, that is where we establish the efficacy of the new drug. Meaning, we are going to give the drug to patients with the disease. So if this is a drug for heart failure, then the company or the researcher will be looking for volunteers with heart failure also, and give them the drug and then observe if the drug is really effective. So itong Diuretics is still in its phase 2 clinical trial. However, its mechanism of action has shown to be the same with that of the digoxin. This also inhibits sodium-potassium ATPase, leading to the influx of calcium inside the cells of the heart. Okay? And this is also considered, syempre, an inotropic agent. It can increase the force of contraction. Okay? So, what happens sa phase 3? Since this is phase 3, ituloy na lang natin yung discussion natin sa phase 3. Sa phase 3 class, we establish both safety and efficacy of the drug, wherein yung pagkakaiba lang talaga is the researcher will be adding more volunteers with the disease. Kung example, in phase 2 clinical trial, we have 100 volunteers with example heart failure, and then we have established that it's really effective sa mga subjects natin. Then sa phase 3 we will add more. So example, gagawin natin siyang 500 or 300 volunteers who will be taking this new drug. Okay? And thus establishing both safety and efficacy. Phase 4 class for the clinical trial is called post-marketing surveillance, meaning dyan, the drug is already out in the market. After phase 3, out na siya sa market, ibebenta na siya sa market, gagamitin na siya, and nagpo-post-marketing surveillance na lang. For example, untoward reaction, mga side effects and mga adverse effects that are not yet observed during the phase 1 to phase 3 clinical trials. Okay? So again, Istaroxime is still on its phase 2. Now, aside from Istaroxime, we have another drug that is not also commonly used for heart failure, but nevertheless, pwede din siyang gamitin. We have the levosimendan. Okay? This is the name of the drug. Levosimendan. Ano naman ang activity nito? Paano siya nakakatulong sa heart ng patient with heart failure? This one sensitizes the troponin system. It's a system class in the heart, sa heart muscle mismo, that needs calcium para mag-contract. Okay? So if this sensitizes the troponin system to calcium, the more na may calcium ka dyan, nagiging mas sensitive yung heart muscle, makakatulong siya sa pag-contract. Okay? Maging sensitive na yung troponin system, yung heart muscle sa calcium. So there will be positive inotropic activity. Now there is an additional activity for levosimendan. It appears to inhibit the phosphodiesterase enzyme, and that will cause vasodilation. Wait lang ha. Let me illustrate what happened. I'll just connect my tab and my pen, so that we will have a picture kung what is the relationship of inhibiting the phosphodiesterase enzyme to the vasodilation. Oops. So, gano'n naman. Sige, tag-carry sa itong bag, back and forth sa balay. So, wala ang pen for dito. Yeah, wait lang. Okay. Sige. So actually, si phosphodiesterase enzyme is used to degrade CAMP to AMP. This is PDE here. PDE again is called phosphodiesterase. This is an enzyme that will degrade CAMP to AMP. What is CAMP? CAMP is cyclic adenosine monophosphate. And then syempre kung AMP, adenosine monophosphate na lang yon. So, anong ginagawa nito sa body? This one is like a chemical messenger, secondary chemical messenger in the body. ano lang siya, just like hormones and neurotransmitters. Messenger, chemical messenger siya sa body, pero this is more specific. Kapag you have a lot of CAMP in the body, it will always cause vasodilation. So definitely this can decrease the BP. Now, in the presence of the phosphodiesterase enzyme, si CAMP class madedegrade. So, magiging AMP siya, and then you cannot utilize that as a vasodilator anymore. Therefore, if we give a drug that will inhibit this enzyme, the phosphodiesterase, we will not have the AMP, and we will have an increased CAMP level in the body that will again help us for the vasodilation. Okay, that will aid the decrease in our BP, and at the same time it can help the heart no pag nagdilate yung mga blood vessels. It can also help the heart na magkaroon ng more supply of blood para may supply din sa oxygen. So dalawa yung activity ni levosemindan. Number 1, to increase the sensitivity of the troponin system of the heart to calcium para sa contraction, and that is again an inotropic activity, and at the same time inhibition of the phosphodiesterase enzyme leading to the increase in the CAMP level, and that would mean there will be vasodilation. Okay? So, dalawang drug na yon. Let's add more. We have the bipyridines. We have 2 drugs here, the inamrinone and the milrinone. The old name for our inamrinone is amrinone class. For milrinone, we have Primacor as our innovator drug. Now, how about the mechanism of action of these drugs? Just like the levosimendan, they inhibit phosphodiesterase type 3 enzyme, leading to increased CAMP level in the heart. So, hindi siya magbe-break down into AMP or adenosine monophosphate. And that will help also, aside from vasodilation, by the way, CAMP itself can also increase the force of contraction. So, hindi lang vasodilation yung activity. Dagdagan nyo siya, class. Yung sinulat ko kanina, si CAMP will not just cause vasodilation, this can also increase the force of contraction of the heart. Okay? So, therefore, the 2, amrinone, and the inamrinone and the milrinone can also be considered as positive inotropic agents for heart failure. Okay, so again, they are vasodilators, meaning they can lower the resistance of the blood vessels for blood flow, and at the same time increase cardiac contractility just by increasing the amount or the level of CAMP. Okay, now where do we use our bipyridines? We have the acute decompensated heart failure. So definitely this is not a drug for a maintenance drug for chronic na heart failure. We give this during acute heart failure. Okay. This one is an emergency drug, and at the same time, if we look at the toxicity, we have here the arrhythmia. The drugs used for heart failure class, especially the inotropic agents, most of them can cause arrhythmia. Since we are disrupting the normal function of the heart in terms of contraction and beating, so muna siya, most likely they will also cause arrhythmia aside from nausea and vomiting. And we have thrombocytopenia also due to bone marrow, and we have, let's add the liver toxicity. What do you mean by thrombocytopenia? Anyone who knows what thrombocytopenia is? Thrombocyte means, ano ibig sabihin ng thrombocytes? Low platelet count. Very good. Pag sinabing thrombocyte, we call them platelets. Okay, diba? Like red blood cells are called erythrocytes, white blood cells are leukocytes, the platelets naman are called thrombocytes. And if you get to see a word ending in pinya, okay, pinya means low. So thrombocytopenia means decreased platelet levels in the body. Okay, next, we have the beta adrenoceptor stimulants. Okay, again, beta adrenoceptor stimulants, especially the beta-1 receptor that we see in the heart. Nasa heart ito, di ba? Beta-1, that's the major location. And stimulating, activating the beta-1 receptor can increase everything. Increased heart rate, increased force of contraction, and even increased conductance velocity. So what are the two drugs that are considered agonist or stimulants of the beta-1 receptors? We have the dobutamine and the dopamine. However, we don't use them class as a maintenance drug since these two are given most likely intravenously IV or parenterally. Now, among the two, si dobutamine is mas ginagamit for heart failure. So nasabi ko na kanina, activation of the beta-1 receptors can increase everything. Contractility, heart rate, and even conductance velocity. If you are asked about the mechanism of action of these two, that's just activation of the beta-1 receptor, or they are called agonists. And at the same time, let's add another one. This increases CAMP synthesis. Okay, again, CAMP is cyclic adenosine monophosphate, which can cause both vasodilation and increase cardiac contractility. But then, again, we don't use this as a drug, a mainstay drug for chronic heart failure. We just use this during acute heart failure, acute decompensated heart failure. So example, in the case of like the so-called heart attack, let's just use the term heart attack class. Pagdalahin ang patient sa hospital, for example, di ba, what we give most likely is the epinephrine. That's our emergency drug. Pag hindi kaya ng epinephrine, that's the time we add the dobutamine just to make the heart contract. Okay? So that is during acute heart failure. Though we give this for chronic failure just to reduce the symptom, pero this will become or this will be given intermittently. Hindi naman magiging maintenance drug, pero intermittent therapy only. Now, take note again, kapag drugs considered to be inotropic, the toxic activity of that in the body is always arrhythmia. Okay, it will disrupt the normal heart rate. Okay, now drug interactions or drug interaction of our dobutamine, ginagawa lang siyang additive with other sympathomimetics. Kagaya ng example ko kanina, during heart attack, the patient is first given with epinephrine during emergency cases na wala silang makita na heartbeat for the patient, binibigyan nila ng epinephrine yon. And then, additional lang ito sa epinephrine, itong dobutamine. Okay? Now, another one, we have the dopamine that can also activate the beta-1 receptor. We have the dopamine. So again, ginagamit pa rin ito sa acute heart failure. Hindi maintenance drug for the chronic heart failure, ha? Acute heart failure lang ito. But what is their difference with the dobutamine? Dopamine class is given if we need to raise the blood pressure of the patient. Okay? At certain dose class, the dopamine can really increase the blood pressure of the patient. Pero when it comes to the mechanism of action, parehas lang naman, activation of the beta-1 receptor. And since this is dopamine, it can also interact with the dopamine receptor, especially in the kidneys. And higher doses of dopamine can also activate the alpha receptors. And that will explain the increase in the blood pressure. Remember the alpha-1 receptor, which is located in the blood vessels. When activated, they can cause vasoconstriction and can lead to the increase in the blood pressure. Okay, so that's the difference between dopamine and dobutamine. Now again, since this is dopamine, it can interact with the dopamine receptors found in the kidneys. This can also affect the kidneys in terms of the blood flow. Activation of the dopamine receptors in the kidneys can increase renal blood flow, aside from its effect on the cardiac contraction and the blood pressure. Okay? And just like our dobutamine, sa acute decompensated heart failure, ito ginagamit as well as sa mga shock, especially cardiogenic shock. What do you mean by shock, class? Anong pagkakalam niyo sa shock? Like anaphylactic shock, cardiogenic shock. What happened to the patient na who experiences shock? What's the common thing sa kanila? Di makahinga? Sige, what else? Yung pinaka-common sa kanila kapag naka-experience ng shock. Yeah, for anaphylactic shock, that is really true.
Allergic reaction, ma'am.
Yeah, anaphylactic shock is the severe form of allergy. And the patient may experience bronchoconstriction. That is why nahihirapan silang huminga. Pero when you say shock, yeah, that is correct. Drop in the blood flow. And that means they're not really with the blood flow, but the blood pressure. Okay, there is again sudden drop of the blood pressure. The patient may experience hypotension. Okay? Yes, that is shock. Pero if you call it anaphylactic shock, the sudden drop in the blood pressure is due to the effect of histamine. So it's called the severe form of allergy. Okay, so again, there is a drop in the blood pressure, and since there is a decrease in the blood flow, that means the organs cannot get enough oxygen also. Okay? Tama yun siya. Heart cannot pump enough blood and oxygen. That is cardiogenic shock. But that is also true for anaphylactic shock, but it's more on the effect of histamine in the body, and that includes bronchoconstriction also for anaphylactic shock. What is our drug of choice for anaphylactic shock? Again?
Epinephrine, ma'am.
Okay, very good. Pero for cardiogenic shock, we give dopamine, ha? And then again, since this is considered an inotropic agent, this can also cause arrhythmia. Okay, and this is also used as an additive with other sympathomimetics. If epinephrine is not enough, we give additional dobutamine, and then if dobutamine is not enough, then add dopamine. Okay, just for the patient's heart to start beating again para may increase ang force of contraction. Okay, any question or clarification before we continue with the drugs without positive inotropic effects, but they are still used in heart failure? Still have 30 minutes. I want to really finish this for your exam. Wala question? Sige, dito tayo sa drugs without positive inotropic effect ha. So they have nothing to do with the force of contraction. Nevertheless, they are used for heart failure. Take note of that. Ginagamit pa rin sila sa heart failure, pero wala silang direct effect on the contraction of the heart. But actually, even though they don't have the direct effect on the contraction of the heart, they are our first line therapy for chronic heart failure. The patient gets diagnosed with heart failure. These are the first drugs we give the patient. So what are those? Actually, we are done discussing them sa anti-hypertensive na chapter. So, i-run through ko lang siya kasi parehas lang naman. Walang pinagbago sa activity. Walang pinagbago in terms of the mechanism of action. Okay? Dagdagan lang natin yung kanilang clinical application. Aside from being an anti-hypertensive agent, ito sila class are also drugs for heart failure. So number one, we have diuretics and vasodilators, which are important for acute heart failure. They are not just given as mainstay drug, as maintenance drug for chronic heart failure, but during acute heart failure, example, nag-heart attack ang patient natin, we also give diuretics and vasodilators. Okay? Si diuretics talaga, mainstay talaga ito for heart failure management. Kasi most of the heart patients with heart failure class, diba, may problema sila sa circulation. Their heart cannot really pump enough blood, no? And the patient may experience edema wherein the water in their blood will be pushed out to the tissues, and then again they will experience edema class. So most likely, since may edema naman yung patient, and at the same time we will reduce the blood volume para hindi mahirapan ang blood, kaya binibigay natin si diuretics. And again, naging mainstay sila sa heart failure. They have nothing to do with the heart muscle directly, but they can help in the heart failure by, again, number one, reducing the fluid, reducing the blood volume, and treat edematous conditions. Okay? They may reduce the venous pressure, the blood pressure also, syempre, na mention na natin yan last time, and the preload. Kasi nga, na-decrease na yung blood volume. So what are the examples of the diuretics used for heart failure? We have the potassium-sparing diuretics like spironolactone and eplerenone, or we call them aldosterone antagonist na mga diuretics. Most of the time, we partner them with ACE inhibitors kasi studies showed na combination of these drugs can decrease both morbidity and mortality. Yung mga nagkakasakit ng heart failure and at the same time namamatay sa heart failure. Because remember, aldosterone, since they are aldosterone antagonist class, and ACE inhibitors class can also decrease the production of aldosterone in the body. Please review the RAAS, the renin-angiotensin-aldosterone system. Si aldosterone class 7, di ba, too much aldosterone in the body can cause water and salt retention. Magre-retain yung water and salt in the body. And that may also damage the heart muscles, and at the same time maging insensitive yung baroreceptors natin. Remember, the baroreceptor reflex center are the responsible in the moment-to-moment adjustment of the blood pressure. So yun. Kaya malaki yung benefit if we are going to combine the aldosterone antagonist diuretics and the ACE inhibitors. So just a quick run through, we have the following diuretics that we can give to our patients with heart failure. We have the loop diuretics. These are the loop diuretics here. Again, their action is on the thick ascending limb of the loop of Henle. They inhibit reabsorption there, especially the sodium chloride. So definitely maiihi yan siya. Okay? So again, run through lang, no, mag-decrease yan lahat, the salt and the water. Therefore, sa heart, magde-decrease yung blood volume, both the preload and the afterload. And since urine is water, edematous conditions may also be treated. So aside from hypertension and edema, let's add both acute and chronic heart failure for our loop diuretics. And then, dadaanan ko lang ito since tapos na tayo nito last time. Okay, paki-review yung toxicity natin with the loop diuretics. And then we have thiazide diuretics. During our discussion with the diuretics, marami sila, di ba? But the most common kasi na ginagamit na thiazide diuretic is the HCTZ. So we have the HITAZ here. Another, again, yung dapat yung tandaan, sa part ng nephron siya nag-act, it's on the distal convoluted tubule. The effect will be the same with that of the loop diuretics, especially furosemide, pero this is just less efficacious. Less efficacious siya since magkaiba sila ng parts sa nephron nag-a-act. Medyo konti lang yung nare-reabsorb in the distal convoluted tubule. So again, aside from hypertension, let's add the mild chronic heart failure and the hypercalciuria. Please review on the hypergluc. That is the toxicity of our thiazide diuretics. Hypergluc pala, hypergluc. Okay. And then the aldosterone antagonists, we only have two, spironolactone and eplerenone. Among them, spironolactone yung may activity on the mineralocorticoid and steroid mismo, no, sa adrenal medulla. And ito yung nagkukos talaga ng gynecomastia. Pero sa ang part sila sa nephron nag-take ng action, it's on the collecting duct or the collecting tubules ng nephron. So the same effects, excretion of water and salt, and thus it will reduce remodeling of the heart kasi mag-decrease din yung volume yung blood volume, hindi mahihirapan in terms of pumping of the blood or blood flow, thus reducing mortality. So we use them for hypertension, for chronic heart failure, and let's add the aldosteronism since they are considered aldosterone antagonists. Okay, so in the case of example, merong adrenal tumor, maraming aldosterone yung nare-release, or in the case of cirrhosis. Okay. And then, syempre, since they are also considered potassium-sparing diuretics, si potassium magsistay in the body, and if masobrahan, the patient may experience hyperkalemia. And this is anti-androgen. Please add N. Anti-androgen. Ito na yung tinatawag ko na gynecomastia, especially for spironolactone. Okay? Next, we have the ACE inhibitors. ACE means angiotensin converting enzyme. So please again review the RAAS system, the renin-angiotensin aldosterone system. That is the pathway where we can see the activity of the ACE inhibitors. We are going to inhibit the enzyme ACE for the angiotensin 1 not to be converted to angiotensin 2. Kasi pag meron ng angiotensin 2, it means it can bind to its receptor and can cause vasoconstriction, leading to increase in the blood pressure, and it can also increase the production of aldosterone, leading to water and salt retention. So again, i-inhibit natin yan para walang salt and water retention, madidecrease yung fluid in the body, madidecrease yung preload sa heart, hindi siya mahihirapan when it comes to the pumping. Okay? Ayan yung mga activity ng ating ACE inhibitors. Kapag wala tayong angiotensin masyado, kasi madidecrease din yung sympathetic activities like the release of the norepinephrine. So again, mechanism of action, this inhibits the ACE enzyme and mai-inhibit ang formation of the angiotensin 1 to angiotensin 2. The effects, it can cause dilation. Again, walang vasoconstriction pag wala tayong angiotensin 2. Ma-reduce ang aldosterone and that will lead to increase in the cardiac output and ma-reduce yung pag-remodel ng heart. Hindi siya mag-hypertrophy. Hindi siya mag-cardiomegaly. So we have here, aside from hypertension, again, let's add the chronic heart failure and the diabetic renal disease. Remember, I have mentioned last time that our ACE inhibitors are also given to diabetic patients even in the absence of hypertension because our ACE inhibitors have kidney protecting activity, especially the decrease of proteinuria para walang protein yung urine. Okay, what's our problem with our ACE inhibitors? Single out ka talaga itong dry cough. Kasi kapag hindi na ma-tolerate ng patient natin yung dry cough, that's the time we are going to discontinue using the ACE inhibitors and shift to ARBs. That's angiotensin receptor blockers. Okay, so that is the next topic. Nagdali ko. I have limited time and I need to finish this. So the ARBs, these are the drugs that end with sartan, like losartan, and then we have candesartan here, which we use if the patient is already intolerant of the dry cough caused by the ACE inhibitor. Okay, now what is their mechanism of action? They just inhibit binding of the angiotensin 2 to its receptor. Okay? Dito, nabuo na si angiotensin. Ang i-inhibit na lang natin yung binding to the receptor. Unlike the ACE inhibitors, wherein we really inhibit the formation of the angiotensin 2. Okay? So, parehas lang sila ng gamit ng ACE inhibitor. Except that we use them if the patient can no longer tolerate the dry cough caused by the prills. Okay? So sa toxicity, walang dry cough dito. Meron lang, parehas sila with the hyperkalemia and the angioneurotic edema or the angioedema which I discussed last time. Okay? Now, other drugs that we can also use for heart failure, we have the Nutrioretic Peptide. Ito, ginagamit ito for acute, not for chronic. Acute heart failure. So, example of a Nutrioretic Peptide, we have the Nesiritide or the Natricor. Ano naman ang mechanism of action nito? This activates the brain natriuretic peptide na receptor. And kapag kayang receptor na yan na syempre makikita sa brain natin ma-activate, it will lead to the increase in the CGMP. So iba ito ha, iba itong CGMP, iba yung CGMP sa Manoff. Sa Manoff, that's current good manufacturing practices. But for pharmacology, CGMP is cyclic guanosine monophosphate. It's almost similar to the CAMP. CAMP is cyclic adenosine monophosphate. Ito, cyclic guanosine monophosphate, but actually they have the same activity, and that is to dilate the blood vessels. When you say reduction in the venous and arterial tone, it means relaxation of the smooth muscles in the blood vessels, and that will lead to dilation. Okay, so here it is. We have the vasodilation, and at the same time, since this is called a natriuretic peptide, they can also cause diuresis. So yan yung gamit ng ating natriuretic peptide class. Pero again, ginagamit lang natin ito during acute decompensated heart failure. Hindi siya as a maintenance drug for chronic heart failure. Okay? What's the problem with this? Since this can cause urination always, it can cause changes in the kidneys. It can damage the kidneys itself. And since it can cause dilation of the blood vessel, this may also decrease the blood pressure or leading to hypotension. Okay? So other natriuretic peptide that we have the atrial natriuretic peptide, example, the peritide and the urodilantine, the olaritide, parehas lang sila. Okay, mga natriuretic peptide natin ito. So what are the examples of our atrial natriuretic peptide? We have this one, the bosentan and the tezosintan, which can also activate. This is orally given and can activate, not activate, inhibitor of the endothelin. So if you can still remember our first discussion, na-mention ko si endothelin class, kasabay sila ni nitric oxide, ni NO. These are endogenous substances released in the body. So endogenous talagang pinoproduce ng body natin. Pero ano yung kaibahan nilang dalawa? Similarity pa pala muna. Similarity is they are vasoactive. When you say vasoactive, they have an activity on the blood vessels directly. Okay? Pero endothelin is a vasoconstrictor, while NO, nitric oxide, is a vasodilator. So yan yung kaibahan nila. Therefore, if we give patients either bosentan or tezosintan, by the way, Traclear is a brand name, then we inhibit the endothelin. Therefore, there will be no vasoconstriction. Okay, so these are other drugs for our heart failure. Aside from that, we also have vasodilators. So, syempre, we dilate blood vessels para ma-reduce yung preload sa heart. Hindi masyadong maka-accommodate ng maraming dugo. I mean, yung pag mag-dilate kasi yung mga veins natin, there will be reduction in the preload of the heart. Konti lang yung dugo, pero mare-reduce din yung afterload. That is through arteriolar vasodilation, pwede din both. So ano itong mga vasodilators na ginagamit natin for acute heart failure? We have the ISDN, or the isosorbide dinitrate, which is a venodilator only. So we only dilate the veins para, that is actually to aid the heart, no, para hindi siya mahirapan in the pumping, okay, of the blood. Wala masyadong resistance to flow. Kasi pag nag-dilate, tapos, kung hindi kasi nag-dilate ang blood vessels pag-push or pag-pump ng heart sa blood, meron tayong tinatawag na resistance. Magre-resist yung mga blood vessels natin sa pag-accommodate sa blood. Therefore, if we are going to dilate, bababa yung resistance niya, it can aid sa flow ng dugo and hindi mahihirapan yung heart nun. Okay? And then, again, we have the ISDN class. This is actually a nitrate. Kapamilya ito ng mga nitrates natin like nitroglycerin. So since this one is a nitrate, ang mechanism of action nito is the release of the nitric oxide in the body. Remember, na-mention ko kanina, nitric oxide is an endogenous substance released in the body, and they have direct action on the blood vessels, meaning they are dilators of the blood vessels, especially the veins. And they may activate also enzymes like guanylyl cyclase, but this enzyme is just actually used to produce the nitric oxide. So pag narinig niyo yung nitric oxide, automatic, that means there is vasodilation, ha? So in this case, venodilation lang siya, so we only have the veins. And this will reduce preload of the heart and at the same time ventricular stretch. Kasi during the preload, 'di ba, magse-stretch yung yung heart muscles to accommodate the blood. But since there is venodilation, hindi masyadong magre-resist yung flow sa blood doon sa papunta sa heart. So hindi masyadong magtatrabaho yung heart no in terms of stretching. Okay? So the preload class, bababa yun siya, yung force na i-exert niya just to accommodate the entrance of the blood. Okay? So saan natin ginagamit si ISDN? Si Isordil, ang brand name nito sa market na commonly used, we have the Isordil. So we will have a separate discussion of this one, the angina, but we also use that for both acute and chronic heart failure. Okay, just to dilate the blood vessels. Okay, but since we are dilating the blood vessels, that means na there will be decrease in the blood pressure, and the decrease in the blood pressure will cause a reaction to the heart na papabilis yung heart rate, thus the so-called tachycardia. And take note, I have highlighted this one, headache. Kapag ka sumasakit ang ulo natin, class, that means nag-experience ng dilation yung mga blood vessels sa ating ulo. And because of that dilation, pain receptors will be stretched. Kaya masakit ang ulo natin. Therefore, if we are going to give the patient vasodilators, talagang meron talaga yung headache. Kasi when you give the patient drug, hindi lang naman yung mga blood vessels sa heart yung nagkakaroon ng drug. The blood is being circulated all over the body. Therefore, including sa nagdadilate yung mga blood vessels natin sa ulo. And then again, nasi-stretch yung pain receptors leading to headache. Okay? Now, ISDN is a vasodilator. Ito namang hydralazine is an arteriolar dilator, but they have the same mechanism of action, and that is through the production of nitric oxide in the endothelium, in the blood vessels mismo, leading to dilation. So the dilation will reduce the blood pressure, syempre, and this will reduce the afterload. Kasi arteries man, ito yung mag-accommodate ng blood pag-pump ng heart. So since nag-dilate na siya, hindi na masyadong ganun na effort ang i-exert ng heart just to pump the blood. Okay? So toxicity, we have here the tachycardia, kasi decrease in the heart, in the blood pressure will always lead to the production of norepinephrine as a mechanism, a coping mechanism of the body for the decrease in the blood pressure. Ipapabilis talaga ang heart rate. So thus we have the tachycardia. And then we have fluid retention. That's our problem with hydralazine. And ito yung pinaka-board exam question. Hydralazine is one of the drug that causes SLE-like symptoms. So, systemic lupus erythematosus. Okay? The nitroprusside naman is both ito, combined arteriolar and venodilation. And they have the same mechanism of action, and that is the release of nitric oxide through activation of the guanylyl cyclase. This is the enzyme we need for us to produce this endogenous substance, the nitric oxide. Okay? Sige, nawa lang net. So there will be marked vasodilation and everything will be reduced. When you say ma-reduce, reduce yung preload and afterload, that's the force that the heart exerts during accommodation of blood in the heart, and at the same time during sa pag-pump niya ng heart going to the body. Marireduce yung effort niya dyan because of the vasodilation. There will be decreased capacitance and resistance of the blood vessels. Okay, so when do we use our nitroprusside? Syempre for heart failure, especially acute heart failure. And na-mention ko na to last time, ginagamit natin reserve drug for hypertensive emergencies, or that's what we call malignant hypertension. So ang problema, since both of the arteries and veins are dilated, there will be excessive hypotension. And na-mention ko na din to last time, since nitroprusside is made up of cyanide, that the patient may be at risk of having cyanide toxicity. Okay? Questions? Kaya pa? Dagan kayo. Uruton dyan ako nino. Uruton lang ako ni siya. I have 10 minutes to finish this. And I have more than 10 slides. So let's just finish this. Yeah, nagpaspas jud ko karon kay I don't have time anymore and it's your exam on Wednesday. I don't have class na on Wednesday kaya nagdiretso-diretso jud ko class. Anyway, this is being recorded. I'll be giving you a copy of the record. Okay? So beta blockers. Kanina yung diniscuss natin na inotropic drug, beta agonist yun, beta 1 agonist, si dopamine o si dobutamine. Ginagamit sila for heart failure, especially acute heart failure. Pero itong mga blockers, mga antagonist natin, ginagamit din sila for heart failure. So both agonist and antagonist can be given to heart failure. So beta blockers, the olols, our olols, they have syempre yung baliktad na activity on the beta-1 receptor. They block beta-1 receptor and that will lead to decrease in heart rate, decrease in the force of contraction, and decrease in the conductance velocity of the heart. Pero magkaiba sila kasi si beta-1 agonist, dopamine and dobutamine, ginagamit sila for acute heart failure wherein we need the heart to really exert effort and increase in the contraction. Ito naman ginagamit to sila for chronic. So this will become a maintenance drug na ipapahina natin yung heart rate, ipapahina natin yung force of contraction, ipapababa natin yung ating blood pressure. Okay? Para ma-reduce yung heart failure mortality. Bakit? Paano natin siya i-explain? Bakit ma'am, may heart failure na nga yung patient? Mahina na nga yung contraction ng kanyang heart. Kulang na nga yung blood supply, yung oxygen sa body. Bakit natin pahihinain with the beta blockers? Kasi class, ganito, may problem nga yung patient sa heart and kulang yung blood supply no, yung oxygen. Pero kasi kapag may heart failure na siya daan tapos papatrabahuin pa natin ng papatrabahuin yung heart, mas mabilis yung kanyang pagka-damage and mas mabilis yung kanyang remodeling, mas mabilis siyang lalaki kapag papatrabahuin mo siya na may sira na nga siya. So what we are doing with heart failure is iso-slow down natin si heart through the beta blockers para hindi siya mag-exert ng talagang grabbing work just to pump blood in the body. We will give beta blockers to slow down the progress of the disease. Okay? So kaya i-reduce natin yung lahat for chronic heart failure. Hindi natin papabilisin yung trabaho niya para hindi siya mabilis masira. Again, that is true for chronic heart failure. This is the beta blockers. Okay? So, na-mention ko na to last time, yung mga toxicity ni beta blockers, that especially for non-selective, they can really cause bronchospasm kasi they can also inhibit the beta-2 receptor. And its effect can also become its toxicity, no, bradycardia, atrioventricular block, kasi pinahina mo nga yung activity ni heart. So yung conductance niya with electricity, mabablock din yon. And it can cause acute cardiac decompensation. Makukulang na talaga yung kanyang sinusupply na blood kasi pinahina nga natin siya. Pero that is actually beneficial in the long run kasi hindi siya masyadong nagtrabaho, hindi mabilis mag-progress yung pagkasira niya. That is the explanation why we also use beta blockers for patients with heart failure. Okay? So lastly, let's just discuss quickly the 4 stages of heart failure development. Yung progress ng disease, hahatiin natin by stages. Kung stage A pa lang ang patient, wala pa talaga siyang signs and symptoms of heart failure. Pero at risk na siya of having one. Example, nasa family history yung heart failure, so definitely may stage A ka na class. Wala ka pang signs and symptoms, pero like high risk ka na talaga, papunta ka na doon. Now, if the patient has signs, evidence pa lang ng structural heart disease. Example, nagpa-x-ray and nakita, enlarge ang heart. Pero wala pang symptoms, wala pang shortness of breath, wala pang yung decreased tolerance, wala pang tachycardia. Lumaki lang talaga, may structural changes lang in the heart, that is stage B. Okay? Pero pag umabot na meron na talagang cardiomegaly, lumaki na yung heart, at the same time, the patient is experiencing signs and symptoms of heart failure already, pero responsive pa siya kung bibigyan mo siya ng ordinary therapy, yung na-mention natin ng mga agents. Ayun, stage C na yung ating patient. Magsa-stage D yung ating patient class kapag hindi na siya responsive to ordinary drugs. Kung magre-require na talaga siya ng special interventions, example, heart transplant or mga angioplasty, yung lalagyan ng balloon yung artery ng blood para lumaki siya and that it can accommodate blood na sa heart muscle mismo. Kapag yung mga bypass na tinatawag, yun na yung kailangan niya talaga kasi hindi na talaga nagre-response yung heart sa kahit anong therapy, stage D na yon. Okay? Now, pag umabot class ng stage C ang patient, ano nga yung stage C? The patient has structural problem na, so there is cardiomegaly and at the same time full-blown na yung signs and symptoms of the heart failure, ika-classify natin siya. So, stage C ha, tapos under sa stage C, we have classification. Pag class 1 pa lang na failure, wala pang limitation with the ordinary activities. So, magagawa niya pa rin yung mga ordinary activities. Hindi niya lang magagawa yung greater than ordinary exercise. So, pag padagano na nimo siya dugay kaayo, padagano na nimo siya, dili na niya kaya. Magkakaroon na talaga ng signs and symptoms. Pero kung normal activities lang like nang hugas lang siya plato, nanilhig lang siya sa ilang sala, that's ordinary activities, wala siyang mafe-feel na signs and symptoms. That is again class 1 failure. Okay? Stage C na talaga ito ha, may signs and symptoms and at the same time may structural changes in the heart. Now sa class 2 naman, meron ng slight limitation on the ordinary activities. Okay, slight lang. Kapag example, pinaglaba mo siya, that is actually an ordinary activity, naglaba ka. Pero since class 2 na ang patient, kapag after niya maglaba, makaka-experience na siya ng symptoms like fatigue or palpitation. Okay, so slight limitation yan siya sa ordinary activities. And class 3, wala siyang signs and symptoms kapag ka nagre-rest, nakahiga, nakaupo, walang signs and symptoms. Pero makaka-experience siya ng signs and symptoms like fatigue or SOB or magtatakicardia siya even with the less than ordinary exercise. So may ordinary activities tayo na ordinary exercise. Pero kahit konti pa lang, pinaglakad mo lang siya, example, galing kusina papuntang sala, less than ordinary activity yon. Pero kapag ka-experience siya ng problem sa paghinga, kahit yun lang yung nilakad niya, class 3 na yon ng heart failure. Less than ordinary activity tapos nagkaroon ng signs and symptoms. Class 3. And magiging class 4 yan siya if even at rest class may signs and symptoms ang patient. Nakahiga ang patient, nakaupo ang patient, pero nahihirapan siyang huminga or nakaka-experience siya ng fatigue. Okay? Or nagtatakicardia siya, mataas yung kanyang heart rate. Class 4 yon. Okay? So that's how we classify our heart failure. Banuman. Nahuman dyan ako ang slide. Kasama kasi siya sa exam. Anyway, this is being recorded. Do you have questions? Take note ha, stages muna. Isi-stage mo muna yung heart failure kung saan siya dyan na belong. Again, stage A, wala pang signs and symptoms, pero at risk. Okay? Wala pa talaga siyang heart failure, at risk pa lang, stage A yan. Pag nagkaroon na ng changes sa heart, like lumalaki na yung heart, pero walang nafe-feel na signs and symptoms, B. Pag meron ng changes sa heart at the same time, signs and symptoms, C na yon. And under sa C, doon natin gagamitin yung classification, yung class 1 to 4. Kasi si stage D, ito talagang hindi na ito nagre-respond to ordinary treatment. So kailangan na ito ng mga like bypass or yung mga operation. Okay? Sa class 1 to 4, i-identify nyo saan and kailan nagkakaroon ng signs and symptoms. So si class 1, kapag ka greater than ordinary exercise lang. Si class 2, nagkakaroon ng limitations sa ordinary activities. Si class 3, kahit less than ordinary activities, naglakad nga lang siya sa kusina papuntang sala, nagkaka-signs and symptoms na. And then ito, class 4, even at rest, may symptoms na ang patient natin. Okay?